Welcome to the Pancreatic Cancer Action Network's webinar, Genetics of Pancreatic Cancer. My name is Sheila Bott, and I'm the Manager of Scientific and Medical Affairs for the organization. At the Pancreatic Cancer Action Network, our goal is to give you hope through better resources so you can make informed decisions. Patient Central can provide free, personalized information on many topics, including pancreatic cancer specialists and treatment options. Contact Patient Central at 877-2PanCAN or email patientcentral@pancan.org. I would like to take this opportunity to thank our webinar sponsors, AstraZeneca and Ipsen, and to thank our scientific and medical affairs industry members, AbbVie, AngioDynamics, AstraZeneca, Ipsen, Pfizer, Rafael Pharmaceuticals, TriSalus, and TYME. The webinar is scheduled for 60 minutes and includes a presentation followed by questions, time permitting. The questions that are relevant to today's topic and more general in nature will be prioritized. If you have very specific questions, it would be best to address them directly with your healthcare provider. A recording of this presentation and the slides will be available under the Educational Events page at pancan.org. Now I would like to introduce our presenter. Dr. Alison Klein is a professor of oncology, pathology, and epidemiology, and she's a trained genetic epidemiologist and statistical geneticist at Johns Hopkins Medicine. She has studied the genetic epidemiology of pancreatic cancer for nearly 20 years. Her research has focused on the discovery of pancreatic cancer susceptibility genes using linkage, sequencing, and association approaches, as well as quantification of pancreatic cancer risk due to familial and genetic factors. Dr. Klein is the director of the National Familial Pancreas Tumor Registry, the largest single-site registry of familial pancreatic cancer in the world. She's also a member of the Scientific and Medical Advisory Board for PanCAN. Dr. Klein, I will now turn the presentation over to you.
Today, and to talk to you all about what we know about the genetics of pancreas cancer. So just for orientation, the pancreas is kind of in the abdomen, near the spleen, the stomach, and the small intestine. It is comprised both of endocrine and exocrine cells. I'm sure you all know this. A lot of what we're going to talk about today and a lot of these researches really focus on exocrine pancreas cancer or adenocarcinomas, which are about 90% of pancreas cancers. Again, that's not to minimize the importance of neuroendocrine tumors. They're just genetically a little bit different. Outcomes are a little bit different. Treatment's a little bit different. So if I say pancreas cancer, I'm really focusing on adenocarcinoma, but we do know kind of genetics can also play a role in the neuroendocrine islet cell forms as well. So, I think it's always important to kind of put pancreas cancer, and by training, I'm an epidemiologist, so I focus on kind of global as well as kind of national trends and really see, how things have changed dramatically. One thing that I often ask about is people who hear so much more about pancreas cancer than they used to. And a lot of that is because the global burden, the number of pancreas cancers in the world each year has more than doubled since 1990. So there's almost 500,000 cases in the world in 2017 compared to 200,000 in 1990. Often asked as to why is this? Probably the biggest impact in this is the advancing age in our population. In 2012, 8% of the population was over the age of 65. That's grown slowly, another 0.5% in 2015, but really kind of moving forward is by 2050, over 17% of the world's population will be above the age of 65. And that's global population, that's not US. So kind of important to put that in perspective. So that's one reason. We've also seen more cases and improved diagnosis. This has really impacted more in developing countries or middle-income countries than in the US, where we've had access to CAT scans for a long time. But you really need kind of the ability to scan patients to really identify the cancer as well. In epidemiology, there's both kind of the overall number of cases, but we also look at by age, what are the rates? So for a 70-year-old, what is their chance of developing pancreas cancer in the next year? For an 80-year-old, And so while the prevalence is kind of some of these risk factors has also changed. And so in addition to kind of aging and the overall increase, this age-adjusted rates have gone up a modest amount too. So not as significantly as kind of the overall population, but a little bit in the past year. And why is a couple decades? Why is that? There's more obesity, particularly in the United States. The rates of diabetes and obesity, which are risk factors, have increased. Alcohol, which it's now suggested that very heavy alcohol use. So not your glass of wine at dinner, but individuals who drink 6 or more alcoholic beverages a day is thought to increase risk. And so we've seen the rates of that increase over the past several decades, while kind of public health-wise, we've made tremendous impact in smoking and decreased the rates in the US and other parts of the world, Asia, Africa, it still remains high. If we switch globally to really focus on the United States, we have just under 60,000 cases of pancreas cancer each year. Again, I've been studying pancreas cancer for a while, and when I started 20 years ago, it was about 30,000 cases in the US. So we've seen this doubling here as well as kind of worldwide. It's the third leading cause of cancer death, and the 5-year survival has improved recently and is now at 10%. So as we've made tremendous strides in looking at cancers at other sites, with lung cancer and colon cancer kind of rates decreasing due to smoking cessation and screening, we see that pancreas cancer and liver cancer are one of the few cancers that they're actually increasing as well. So one of my interests in studying genetics is to be able to identify populations that are at higher risk and really moving into understanding kind of pancreas cancer as well as identifying precursors. So pancreas cancers develop kind of through two main mechanisms: a cystic path, and which are macroscopic lesions, so you can see them on a CT scan if they're big enough, as well as, and this is probably the minority of cancers, IPMNs are common in the 7th decade of life. What we've seen is as improvements in imaging, as CAT scans get better, we're detecting more and more of these. Now the challenge is identifying which of those are likely to progress to pancreas cancer versus those that are benign. But most pancreas cancers develop through these pancreatic intraepithelial neoplasia, which are small kind of microscopic lesions. And that's really the challenge, is how do we screen when these changes are not easily impacted on through imaging. So as I mentioned earlier, risk factors for pancreas cancer: cigarette smoking doubles risk, obesity, it's about a 60-fold increased risk, particularly in the individuals who are in the severely obese category. Very heavy alcohol use is about a 60% increased risk, so 6 or more drinks a day. Diabetes has also increased in prevalence. It's a very complicated relationship with pancreas cancer, where it's thought that some individuals who develop pancreas diabetes, particularly individuals who might not fit the classic profile of someone who would become diabetic, a very small percentage, less than 1%, might have developed diabetes due to kind of an early pancreas cancer or kind of precancerous lesions in their pancreas. So this is kind of an interesting group that PanCAN as well as others are focusing on. Can we disentangle just everyday ordinary diabetes from that subset that might have a link with pancreas cancer? Also, individuals with long-standing diabetes, so 10 or more years, might have about twice the risk of pancreas cancer. As well, I'm going to talk a lot about the risk of family history. So having one family member with pancreas cancer about doubles your risk. If you have more than one close family member, it's about 7-fold increased risk. A lot of my research is understanding the genes that kind of drive that. Pancreatic cysts, as I mentioned, are increasingly common. About 3 to 10% progress to pancreas cancer within 10 years. So the vast majority of them stay benign. So it's really balancing and taking only to surgery those that are likely to progress is kind of a critical aspect, as well as pancreatitis, while very rare, kind of longer standing pancreatitis is about a 2 to 3-fold increased risk. So kind of putting genetics into the bigger picture of the available risk factors. So as I mentioned, I'm interested in genetics in part because of really moving forward to kind of better detection and screening for pancreas cancer. One of the challenges with this is that pancreas cancer is a rare disease. Compared to other cancers, fortunately, it's less common, but it also makes it more challenging from an early detection standpoint. So here's an example. If we take 200 U.S. whites, age 65, we follow them into the future for 10 years, one of those 200 is likely to develop pancreas cancer. So we want to develop tools that kind of identify a smaller subgroup, but it's challenging when you start with, 1 out of 200. If you look at these various risk factors, say, for example, cigarette smoking, you take 200 current smokers who are age 65, you follow them for 10 years, and then you have 2 out of pancreas cancers out of the 200. So still very uncommon. So again, from an early detection standpoint, disentangling those two. If you think of other cancers, breast cancer, why is it simpler in a sense? If you take 200 U.S. women at age 65, follow them for 10 years, 8 will develop breast cancer. If you look at a twofold increased risk factor, such as smoking is for pancreas cancer, you move from, to 16 breast cancers in that group. So again, just this idea of how rare it is in the population and the ability to detect it, and the tools to detect it. And so if you find something that decreases risk, it moves it to 4. So it's a bigger kind of change in the absolute number of individuals as you kind of move the screening test. So kind of the goal, if, pancreas cancer, most cancers have a genetic basis. Some of those are acquired mutations, and many of those are, more common. We know the common driver genes, but a subset of individuals have an inherited predisposition, and that's really where my research is focused and is kind of the focus of the rest of this talk for the most part. So what is kind of familial pancreas cancer? Our working definition, while it is kind of imperfect, is individuals with 2 or more close relatives with pancreas cancer. So as I mentioned previously, if you have a single relative, you have about twice the increased risk of pancreas cancer. If you have 2 close relatives, so a sibling and a parent, 2 siblings, you have about a 7-fold increased risk of pancreas cancer. And the more family members you have, again, this risk increases as well. As mentioned previously, I run the National Familial Pancreas Tumor Registry, which is a collection of families. It's a cohort of families affected by pancreas cancer where we follow them into the future. So we can learn about them both by studying their information in them, their family history, what are the other cancers, what is their risk moving forward. If available, we can also study the genetics of the patients themselves and the relatives to identify susceptibility genes. These genes might act independently. They might also interact with environmental factors, so they might have a different effect if you smoke versus you don't smoke. And really, once we identify those genes, the question is, what is the risk of pancreas cancer at specific ages in individuals with those genetic variants? So we have about 8,000 families in our registry, about a third of which are these multiple affected family members. Again, it's worth kind of considering that many of these families have, 2 or 3 pancreas cancers. We don't see a lot of families with kind of 4 or more pancreas cancers, fortunately. Part of that is even in its kind of familial form, many of the cancers don't develop until later in life. So unlike oftentimes you see with kind of familial breast cancer or familial colon cancer, where you think of these very young cases in the familial form, with pancreas cancer, it seems that families with kind of multiple pancreas cancers might get it a little bit younger than most cases, but really not kind of a huge difference. It might be 5 or 6 years younger versus kind of decades younger for pancreas cancer. In the interest of time, just kind of additional kind of breakdown by family history. So if there's 2 close relatives, it's about a 7-fold increased risk. If there's 3 or more, it goes up to about a 17-fold increased risk. And what we see here is there's a difference in age of onset a little bit, but if you have a young onset case in your family and that's the only case, we didn't really see a sizable increased risk of pancreas cancer. We also note that in these families, there do seem to be other cancers that co-occur. Kind of overall, there's about a 40 to a 50% increased risk of cancers at all other sites. If we look at specific sites, we see an aggregation of breast cancer in these families, ovarian cancers in families with multiple pancreas cancers, colon cancers, interestingly, bile duct as well, and then prostate in kind of young onset families. This is interesting. I often get asked kind of, how to manage this. Really, there are no kind of firm recommendations specific to pancreas cancer families right now, but really, for many of these cancers, for breast cancer, for colon cancer particularly, we have effective screening. We have mammography, we have colonoscopy. So it's really important for individuals to, follow the recommended screening, getting their annual mammography, getting colonoscopies according to what is recommended for them. So, how does family history change kind of that dynamics in terms of risk modeling that I was talking about earlier as well? If you have 200 U.S. whites, age 65, and you have kind of a familial pancreas cancer, if you follow them 10 years in the future, now you see kind of bigger changes where we go from 1 case to 7 cases. If I'm going to talk a little bit about one of the genes we know is important is pancreas cancer is BRCA2. Again, if we find individuals with a BRCA2 mutations, we have 6 out of 200. So really at a stage where we can start to get a sizable enough population that the risks of screening are outweighed by the benefits. So I'm going to talk a little bit about the particular genes that are involved in pancreas cancer. But even amongst this group of kind of families with multiple pancreas cancers, we know the genetic basis of about 20%, maybe 25%, and really this 80% of families we're still looking for kind of the genetic underpinnings of it. And that's where the bulk of my research is in, but also in better understanding, what the risks are of pancreas cancer in a family with BRCA2 mutations. So what do we know about BRCA2 and pancreas cancers? If a patient with pancreas cancer goes and gets genetically tested, we know that about 3% of them come back with pathogenic variants in BRCA2. This percentage increases as their family history increases. It's probably 6% if they have a family history of pancreas cancer in one relative, on up to about 17% for 3 or more relatives. As we mentioned, we see this in families without an addition, where there's just 1 pancreas cancer case versus 2 or 3, and it's somewhere in this 3 to 7% range, depending upon the population. If there's a large Ashkenazi Jewish kind of subset to the population, if someone's of Ashkenazi Jewish ancestry, the likelihood that they have a mutation in BRCA2 is higher, just because there's a founder mutation in that population. So they're just more common in general. And it's thought that individuals with a pathogenic variant, or more commonly referred to a mutation in BRCA2, have about a 3 up to a 6-fold increased risk of pancreas cancer. We also see it in families where, there is no family history of breast cancer or pancreas cancer or ovarian cancer. We do see these patients who develop pancreas cancer and sometimes do have BRCA2 mutations. Mutations in BRCA1, which also causes familial breast and ovarian cancer, are also associated with pancreas cancer. Interestingly, it does seem like risk of pancreas cancer is a little bit lower in these families, and they represent only about 1% of pancreas cancer patients versus about 3 or more for BRCA2. Very rarely, but is individuals with familial melanoma, which is caused by mutations in the CDKN2A gene, are associated with an increased risk of pancreas cancer. They are found, pancreas cancer is the second most common cause of cancer death in these families, and they have between a 9 and a 38-fold increased risk of pancreas cancer. So which is akin to about a 17% lifetime risk. So while these mutations are very rare, less than 1% of pancreas cancer patients have a mutation in this gene, their relatives would have, who also carry the gene, would have a very high lifetime risk of pancreas cancer. Lynch syndrome, also called hereditary polyposis non-colorectal cancer, is also associated with an increased risk of pancreas cancer. Again, these are uncommon. If we test an unselected series of pancreas cancer patients, it's less than 1% of cases would have a mutation in one of the genes involved in Lynch syndrome, and they're thought to have about up to an 8% lifetime risk, though some studies have shown kind of a lesser risk than that. Hereditary pancreatitis. So mechanistically, it's a little bit different. Many of the genes we talked about for are kind of cancer predisposition genes that impact DNA repair. So we all acquire changes to our DNA during our lifetime. We have mechanisms to repair that. If your mechanism's a little less efficient because of an inherited mutation in it, or you kind of get a second mutation so you no longer have that DNA repair capability, you're at increased risk of cancer. Whereas some of the pancreatitis genes, PRSS1 most notably, causes underlying chronic inflammation of the pancreas, which can increase risk of pancreas cancer. Again, these are very uncommon, or less than 1% of pancreas cancer patients, extremely rare otherwise, but have a very high, about a 40% lifetime risk of pancreas cancer. PALB2 is a partner and works together with BRCA2. They fix errors in DNA together. Again, it was associated with an increased risk of pancreas cancer, also associated with an increased risk of breast cancer. It's about 3%, or probably less. In our initial study where we found it in 3 out of 100 pancreas cancer patients, familial pancreas cancer patients, sorry. But subsequent studies have shown it less frequent, so probably less than 1% of pancreas cancer patients. Also, the ATM gene, which was initially discovered about 10 years ago and associated with pancreas cancer, is about the second most common gene you found mutated in pancreas cancer patients. So it's about 2.5 to 3%, just below BRCA2. So frequently associated with an increased risk of pancreas cancer as well. So, we've been kind of a history since about the mid-90s up to 2010, where we've identified several pancreas cancer susceptibility genes. Traditionally, because of the cost of genetic testing, as well as the decisions making on kind of, does it impact clinical care, kind of the challenges of it, and also the probability that a pancreas cancer patient or their relative would get testing and would be found to be negative, it wasn't generally recommended to have germline genetic testing for all patients. However, that really changed about 1.5 years, 2 years ago, where larger scale studies were done looking at 1,000 or more pancreas cancer patients, and really finding that kind of 5 to 10% of them have actionable mutations in these genes, meaning their relatives are at a higher risk for pancreas cancer and might benefit from screening for either pancreas cancer or some of the other cancers, for example, BRCA2 mutations, screening recommendations for breast cancer change, hereditary colon cancer or Lynch syndrome, colon cancer recommendations change. We also start to know some treatments that might be more beneficial in this group. So really the first of these studies, the first finding of BRCA2 in pancreas cancer was in unselected, just all-comer pancreas cancer patients. And that was in 1998. In 2015, the group in Toronto looked at all of their surgical patients and found that up to 5% of them had BRCA2 mutations. Similar numbers from Johns Hopkins, Mayo. Dana-Farber also has a study that's in this 5 to 10% range. At the same time, the cost of genetic testing moved from a test that was $5,000 to about $200. So again, cost that was more accessible to many as well. And so here are kind of the risk estimates and the prevalence, so the probability of a pancreas cancer patient having a mutation in these genes. So, for BRCA2 and ATM, it's in this 2 to 3% range. For these other mutations, so BRCA1, as we talked about, CDKN2A, and some others, it's a little bit lower than that. Again, but all combined, it's at this 5 to 6%. So genetic testing got a lot cheaper. We were able to do larger panels where we be able to look at all of these genes together for $200 to $300 compared to $5,000 plus dollars. So again, if not more. So it's really the economics of this has changed, but also our understanding of risk management improved, as well as treatment options. We now have viable treatment options for some patients with these conditions. For example, in the past year, the POLO trial, which looked at the utility of PARP inhibitors in BRCA-deficient pancreas cancer, was shown to have a survival benefit. We do know that immune checkpoint, particularly in mismatch repair deficient individuals, which are those which have Lynch syndrome, is more effective as well. And then there's platinum chemotherapy in BRCA deficient cancers as well that's shown to have better outcomes. So again, benefit to the patient, as well as, if a patient is found to have a mutation, they can share that information with their relatives who can think about what screening decisions are right for them. And so the NCCN guidelines, which are one of the major guidelines for cancer centers, as well as ASCO, changed their guidelines at the end of 2018 to recommend germline genetic counseling and possibly genetic testing for all newly diagnosed pancreas cancer patients. So this was a very big change. And based upon that, and around the same time, I'm part of the GENERATE study, which is funded by Stand Up to Cancer, as well as others, which is really interested in looking at the barriers to access genetic testing for pancreas cancer patients and their relatives. A lot of times, traditionally, the genetic testing and the genetic counseling was a large process. You'd have to have a separate appointment. You'd have to go in to meet with a genetic counselor. This can be challenging for patients who are, in the midst of managing a very complex disease, often not feeling well, to have an additional appointment. So the goal of the GENERATE study is to look at technology, telemedicine, to do kind of virtual counseling and compare that to some of these newer companies. In this case, it's Color Genomics, where patients can kind of work with their provider to get educated on a website and order the test through them. So it's really to look at, what is the optimum balance of kind of genetic counseling and education and how patients like to receive that. So this study initially was focused only on pancreas cancer patients. Now we've opened it up in the past couple of months so that an individual with a first-degree relative, so a parent, a child, or a sibling with pancreas cancer, is also eligible to participate in the study and get kind of telegenetic counseling. As I mentioned previously, we still don't know the cause of 80% of families where there is this clustering of pancreas cancer. And so we're still kind of trying to figure that out. And that's where a lot of my research is. So I always kind of refer to this figure as kind of genetics and genetic susceptibility genes are really a spectrum. You have very uncommon mutations and uncommon in the population that often have kind of a higher risk of pancreas cancer. So we talked about kind of BRCA1, BRCA2, and this is kind of their frequency in the population, not in a person with pancreas cancer, but just in any person in the population. It's kind of far less than 1%, and they have a relatively, a 6+ fold risk of pancreas cancer. On the other end of the spectrum, there are kind of common genetic variants. These are variants that are in 5, 10, 15, 40, 50% of the population that cause a very small increased risk. So an increased risk of 10% of pancreas cancer. And so, but all of these kind of can teach us a lot about the disease. These common variants are a little bit more challenging in terms of kind of how do you manage a patient with them, where these higher risk variants are kind of actionable. So that's where the BRCA1, BRCA2s are, ATM is. But understanding these kind of lower risk variants can teach us a lot about disease. So for these high risk genes, we've looked at many ways to approach them. Oftentimes these cause what geneticists refer to as like a truncating variant, which basically means since DNA sequences encode for protein, someone with a mutation can't make that protein. And so we looked at about 600 familial pancreas cancer patients from about 10 collaborating sites to see if we could find any novel truncating mutations that cause pancreas cancer. This is a route that had helped us find PALB2 and then followed by ATM. And so we wanted to continue to see if we could, using it in more patients, find the underlying cause of pancreas cancer. What we did find is pancreas cancer is highly heterogeneous. Genetics are what make us all kind of different and unique to each other. So we all have lots of variants. So if you compare one person to the next person, going back, within our 600 people, we had 4 million changes per patient. So these are the changes that make us all unique. And to figure out which ones are important for pancreas cancer risk versus which one is associated with all the other variation is the underlying challenge. So, we often look for, multiple patients who have a truncating variant in the same gene, and then comparing them to individuals without pancreas cancer who might not have any truncating variants in the gene and compare those two frequencies. When we looked at our large series, what we really saw was that most of these changes were unique to one or two individuals, and we didn't see any kind of new things that really stood out kind of across individuals. So what that means is it's highly heterogeneous, but there are also many other sources of genetic variation that are not truncating variants. It's just easy to understand what they do, whereas the other sources of variation are a little bit harder to detect and a little bit harder to understand. And so we're continuing to kind of dig a little bit deeper now. But that initial pass shows us it's heterogeneous, which we kind of knew, because even among those families that do have, where we can identify the mutation, there's many different genes that act there. So again, within the families we knew about 10% had a mutation. About 3% of them had an ATM mutation. So again, the cause of most pancreas cancer is still something we're trying to understand. So in addition to these high risk variants, on the other end of the spectrum, as I talked about, there's these kind of lower risk variants. And so we're continuing to study those. The typical tool we use, and you sometimes hear about, are called genome-wide association studies, where you take genetic markers that look at, you can identify, all of those 4 million or the many genetic variations in an individual. So about 11 million points per person. And you can compare those in individuals with pancreas cancer to those without, and look for differences in frequency between these two groups. So we've done this kind of collaboratively when there's about 10,000 cases and about 12,000 controls. We're planning and moving forward on our next study where we're doubling this, or more than doubling this, and this is a collaboration between, again, 25 or 30 sites led out of Johns Hopkins, as well as the National Cancer Institute. And together we're doing this with all of our collaborating sites to kind of really expand this. But we did find, these little, this is called the Manhattan plot, because you want to be at the top of the skyscraper, because that shows you what's really different between these two groups. And so far, we've had a list of genetic variants, and their association with pancreas cancer. Though, kind of if you take this and compare it to BRCA1, BRCA2, where the odds ratios, or this measure of the differences or increased risk, was about 6 between patients with pancreas cancer to those without. These differences are really small. So, a 10 or 20% difference in pancreas cancer risk. So as I mentioned, these are a little bit hard to act on. If you take, again, your 200 U.S. whites, age 65, follow them 10 years in the future, you have one with pancreas cancer. If you have a genetic variant, you have kind of a subgroup of the population, and one of those people have a little bit increased risk. So it doesn't even get you another whole person with risk. So again, interesting. Maybe if we combine many of these together, it can move the needle a little bit, but these things are very common, and an average person has an average number of variants and is at average risk. And it's very uncommon to have a lot of these to really, to move risk distributions a lot. So here's kind of a schematic of once we take what we know about pancreas cancer and put in our known genes, we know a lot of these very high risk, a lot of them very low risk, and we're trying to kind of fill in the middle a little bit and fill in what we're missing. The reason the middle is kind of empty is because we really haven't had the tools to start fill them in, but the Human Genome Project isn't really that long ago, and so we're really only starting to understand what changes the specific change to our DNA means, and it's very hard. It's easier once they're in a gene, it codes for a protein, but that's only 1% of the genome. The other 99% of the genome, these regions could be important, and really understanding what they do is particularly hard and challenging. So kind of what are the future studies? There's additional analysis of these very rare variants, as well as kind of moving forward on those common variants as well, and kind of filling in the middle of that range, as well as either end. We know we haven't captured everything on either end of the spectrum. Another area that at last, I would say we're beginning to able to do is, you notice a lot of what I talked about in the examples kind of focused on white individuals, and that is because we really lacked representation in genetic studies of pancreas cancer, or pretty much any studies of pancreas cancer in non-European ancestry populations. Part of that is traditional barriers in terms of recruitment and enrolling minority populations into studies, whether they're clinical trials or observational studies, for very important historical reasons, and a lot of unethical behaviors in the past make these populations reticent to join studies. But also the challenge is, we talk about pancreas cancer being rare in the United States, and if we go back 10 years, there were 3,000 pancreas cancer patients in African Americans in the U.S. each year. That too has increased to about 5,000. Many of there are additional challenges in terms of while the incidence is higher in African Americans, they still comprise kind of a small number of cases annually. Also, there is historical barriers. While the age is a little bit younger, they're less likely to be referred to high-volume referral centers. They are more likely to have locally advanced or metastatic disease, which results in a shortened survival, which makes it more challenging to kind of span widely and enroll patients into studies. And their minorities, particularly African Americans, are less likely to receive care that follow these NCCN guidelines. But we really need to do better. I would say studying pancreas cancer is challenging in terms of other cancers. Doing minority studies in cancer is challenging. In putting those two together makes it a bigger challenge, but there's no reason. I think we just need more effort and more to do it. So that was specific to pancreas cancer. Genetic studies as well. You can't go a day without hearing about a genetic study in the news. But But if you look at, in many genetic studies, once the ability to identify people using kind of, you remove age, you remove birth date, you kind of de-identify the data in that regards. And then with researchers share the kind of the genetic data broadly to facilitate future research. And there are protections for that, of course. But if you look at these databases, overall these databases are predominantly European ancestry populations and very little kind of outside of European populations. Why is this important? It is on many levels, but also we know that genetics are what make us unique. The frequency of these variants vary from population to population, and so if we develop tools that work only, if we develop tools in the European population, they might only work well in the European population, and they won't translate. And really, we want kind of everyone to benefit from these studies. So I and others have spent a lot of time kind of pulling together as many studies as we could that have a small number of African Americans with pancreas cancer, and together we have a large number, large being about 1,000 cases and 1,000 controls. And so we're going to sequence these patients to start to look for changes, to see if, one, we find anything novel that might not be in the European population, but also see if what we found in the European population is actually relevant and still important in the African American population. This is a first step, and we need to kind of expand these studies vastly, but I'm excited that we're actually able to take this first step. In addition to kind of understanding genetics, we do need to figure out how to screen better care for individuals who have a genetic predisposition or are just at risk of pancreas cancer itself. So that's the challenge. One, we need to identify high-risk populations, but we also need better screening tests. Currently, the guidelines do not recommend pancreas cancer screening for the general population. The U.S. Preventative Task Force recently, a year ago, gave them a recommendation of D for screening in high-risk in general population. There are exceptions to that. Individuals with a family history or individuals with a mutation in one of the genes we talked about could consider being screened. The guidelines recommend that screening is part of a clinical trial whenever possible, or at a center with experience in screening and detecting and caring for pancreas cancer patients or those at risk. Why is that so important? It's because it's not only the screening test itself, but the subsequent decisions about when to intercede and when to not are really difficult. You're balancing an individual's kind of risk and probability of developing pancreas cancer, and how do we intercede? Well, that in that high-risk group, it's surgical resection of the pancreas, which is a procedure in and of itself has a 1% to 2% mortality rate at the best places. So you really need to be sure that individual is going to develop pancreas cancer in their lifetime before you intervene. And that is really the challenge, is making those decisions and having enough experience in a multidisciplinary approach to be making the best decisions we can for those patients. Really kind of the goal is to kind of prioritize who is at highest risk. How do we screen these people and differentiate, do they have PanCANs, do they have IPMNs, and then how do we intervene, and intervening in only these highest risk individuals. If we can't make progress and detect and extend lives and effectively screen high-risk individuals, it's going to be even harder in lower-risk individuals, where, again, the negatives of screening and the risks associated with it outweigh the benefits. What is promising on the horizon? There's a lot of interest in kind of blood-based early detection tools, whether they're circulating tumor DNA, protein, and other measures. And that's really, small, each cancer has somatic mutations or acquired mutations that are shed from the cancer that can be shed into the blood. And if you take a blood sample from these mutations, you might find these cancer mutations kind of in the circulation. Maybe before a cancer shows up on imaging is the hope, and to use that to guide early detection, or the tumor sheds protein kind of similarly. These tools are promising. They're promising for pancreas cancer. Looking at KRAS, which is the most common kind of driver mutation of pancreas cancer. So it's in 90+% of adenocarcinomas of the pancreas have KRAS mutations. So if we look at the ability to detect this with protein biomarkers as well, kind of by stage of pancreas cancer, while it's not perfect and it doesn't detect all cancers, the ability to detect some pancreas cancers early would be a huge step forward. And so, these markers may be able to detect some early stage cancers and some smaller cancers. This is a group that, albeit was undergoing surgery, so we already knew they had cancer. How this kind of employs in larger population-based studies, that work is really ongoing. And these tests, while this is focused on pancreas cancer, they're often kind of multi-cancer panel tests, so looking at driver mutations in multiple cancers together, as well as really kind of the hope in doing these large scales to really see if they can identify a group that would warrant additional screening. Similarly, in high-risk individuals, so individuals with a familial pancreas cancer who are over the age of 55 or 10 years younger than the youngest case, or have a germline mutation. So again, 2 close family members with pancreas cancer. Since about 1998, there's been a study at Hopkins looking at endoscopic ultrasound. In other centers, or we collaborate with other centers are kind of doing similar studies as well for the early detection of pancreas cancer. So if we follow these individuals with endoscopic ultrasound or MRI at an annual basis, can we detect pancreas cancers early in this very high-risk group? Recently, within the past couple of years, the most recent phase of this has been studied. There's been about 400 individuals who've been screened with regular follow-up. Of these, about 13 progressed to pancreas cancer, so about 1% progressed per year. And again, what we did see is within those, some individuals developed pancreas cancer outside of surveillance, and outcomes were not, their survival after diagnosis was not as long. If a pancreas cancer was detected under surveillance, the 5-year survival was, 50-60%, which is better. And also individuals were detected with high-grade dysplasia, or some individuals were detected with neuroendocrine tumor. So we do see kind of extended survival in individuals who were screened as well. So kind of promising first step in the process. We really, additional studies are really needed to really show that screening saves lives and extends lives, and that the risks, at least in high-risk groups, that the benefit of screening outweighs risks. Again, we're also looking at individuals with a pancreatic cyst, really determining individuals who are likely to need to progress and others that are likely to maintain benign. Similar to the kind of blood-based biomarkers, there's a lot of individuals who are, the pancreas cysts themselves contain fluid, kind of sticking a needle into that cyst and looking at the genetics and other factors to differentiate. Cysts that are malignant are likely to be malignant versus those that are likely to remain benign. And kind of additional studies kind of showing kind of management of a test that combines this comp cyst versus kind of standard of care diagnosis, really showing that there's improvements in less individuals who don't need surgery, would be told not to go to surgery with these molecular tests, and then fewer individuals kind of sent to surgery. But really the benefit in this case is avoiding unneeded surgeries, which, as we mentioned previously, have a notable mortality rate. So again, I'm very fortunate to work with kind of a large collaborative team, both at Johns Hopkins as well as kind of our Familial Consortium and the GWAS Consortium, again, kind of a long list of collaborators, far more than would fit on a single slide, and really, kind of support through many, NCI, Stand Up to Cancer, as well as, of course, PanCAN's very important in all of this as well. So where can you go for more information? As always, PanCAN and Patient Central is a wonderful resource for both management of pancreas cancers, knowing about the latest research studies and connecting families with researchers. My research study, the National Familial Pancreas Tumor Registry, and we work closely with the Cancer of the Pancreas Screening Study. Our email address is pancreas@jhmi.org. For more information on the GENERATE study, the website's generatestudy.org. And I think we have a little time for some questions.
Thank you so much, Dr. Klein, for a very informative presentation. Exactly as you mentioned, we do have time for a few questions. So I'd like to jump into the first few. There were some related to family history, those who have one family member, others with two or more who have been diagnosed with pancreatic cancer, and all asking how concerned they should be about themselves or their children. So if you could clarify what counts as an immediate or close family member and then next steps to remain proactive.
Sure. So we do know, so this familial definition is if they have a parent and a sibling or two siblings, so two very close relatives with pancreas cancer, or they could have kind of a parent, a grandparents, kind of in the same lineage, I would say. To talk to their healthcare provider about it, they can think about, talk to a genetic counselor, talk to their healthcare provider. They would be eligible likely for some of the screening studies, for the CAP studies, as well as those at other places. They could look into it as well. As we said, these are best done as part of a research setting where we can learn appropriately how to balance kind of risks and benefits of screening. But it's really, it's complicated because it's not just pancreas cancer. Are there other cancers in the family? The ages, the relationship. So really understanding those, every family is unique as well. But considering these studies is a step forward. If you just have one family member with pancreas cancer, it's about a twofold risk. And right now, we're still learning how to manage the highest risk people. But what that kind of really translates is lifetime risk by age 85 in the U.S. is about 1.5%. A twofold increase in risk means that's about a 3% risk by age 85, just to put that in context.
Definitely. Thank you for sharing that.
Sure.
The next few questions are surrounding those who have lost a loved one from pancreatic cancer. And what would be the next steps for a family to better understand risk, along with should they be looking into a registry or how to contribute to research?
Sure. So I can speak from my registry. And so we do enroll the relatives of pancreas cancer patients. They can provide a questionnaire and we can learn a lot from them. I would say about 2/3 of the families in our registry kind of fall into that subset. Different registries have different kind of inclusion criteria, exclusion criteria. So that's, specific to them, and I can't speak to that. I do know that, I think into kind of managing risk, I think it goes back to the answer for the first question. Each family is unique, and kind of talking with kind of a healthcare provider who's experienced in pancreas cancer families. I think there's a lot more experience out there with it now than there was 10 years ago, but you still hear stories about people who are told pancreas cancer is not genetic and not to worry about it. I wouldn't say worry about it, but I would say, we do know there is a genetic component, and it's worth having an informative discussion about it.
Thank you. For those who have multiple family members affected by pancreatic cancer and have had genetic testing resulting in no found mutations, do they need to keep up with screening or testing regularly?
So the general recommendation now is that they would, because we do know, as I said, 80% of the families with these multiple pancreas cancer patients, we don't know the causative mutation. So only 20% of cases can we find a mutation. And The exception to that is there are individuals who we refer to as quote unquote true negatives. And that's to say, they had a parent who had pancreas cancer, maybe a parent and a grandparent who had pancreas cancer. Their parent was known to have a BRCA2 mutation, and they did not inherit that BRCA2 mutation. In that situation, they kind of fall into this they go back to kind of population-based average risk, whereas an individual with two family members where you don't know the genetics of those two family members would still be considered at higher risk and would be included in screening studies.
Thank you for that answer and explanation. The next question is, can you explain the difference between genetic versus tumor testing? How does one get testing for these? And does it help to have testing to determine which targeted treatments may be beneficial?
Sure. So I meant to touch on this. So these are kind of very different tests. So tumor tests, we're all born with our DNA and our genetic variants. Throughout lifetime, we acquire additional mutations, some of which can lead to pancreas cancer or other cancers. Tumor testing often focuses on those mutations, so these acquired mutations that might have kind of treatment ramifications and can give information. There's also the inherited testing as well, which might lead to different targets. Sometimes tumor testing, they kind of look at both the inherited and the acquired, but most of the time those are only focused on tumor testing, and the test results only report kind of these acquired mutations, not the inherited ones. So it's generally thought that both are important. Those that in the kind of the acquired mutations, that information doesn't impact additional family members because it's not what you were born with, it's what you gained throughout your lifetime. So you didn't pass it on to your children, your relatives don't necessarily share it. So kind of very different tests. And when I talk about genetic testing, I'm talking about kind of CLIA-approved genetic testing, so Invitae, color genomics. There are other tests that are out there. Companies like Ancestry, 23andMe, they more look not at these high-risk variants for the most part, but these kind of more common genetic variants. There's always exceptions to every rule, but really they're very different testing. So kind of a 23andMe test is not a surrogate for kind of germline inherited hereditary cancer testing.
Thank you for clarifying that. The next question is, you mentioned pancreatic juice. What do you think about it as a high specific material for early detection of pancreatic cancer? And do you think the amount and quality of it plays an important role?
I think the amount and quality of it, I'm sure it does. So there's pancreas juice and there's cyst fluid, and they're a little bit different. So cyst fluid is when someone has a pancreas cyst, they take a needle, stick the needle in this cyst and aspirate the fluid out. So that's called cyst fluid. Pancreas juice is used in some of these screening studies, and where you stimulate someone to produce more pancreas enzymes, and then through an endoscopic ultrasound and a little scope that reaches into the common bile duct, you collect that pancreas juice. And the idea being that's another source of fluid that might be closer to whatever is the tumors that are in the pancreas. So it might be a ready source, more readily source, kind of less diluted of these cancer-specific genetic changes. And so that's an area of a lot of research and many different studies looking at it as kind of an early detection source, as well as the pancreas cyst fluid. And again, these are kind of two different areas. I think both have a lot of promise. But again, obviously something I think it's best to study as part of a clinical trial. And we still need to learn a lot more about it, but there's a lot of promise there.
Thank you. And at this time, we have time for just one more question. So how can one find genetic counselors in their area?
So I would say go to the National Society of Genetic Counselors, so nsgc.org has a registry of kind of local genetic counselors. Some of the commercial genetic testing companies, so Invitae, Color, and other, also have genetic counselors who work with them, who you can talk to via telephone call as well. So that's another option if you don't have one kind of locally as well.
Perfect. Thank you again, Dr. Klein, for a very informative presentation. The PowerPoint slides and a recording of this webinar will be available at pancan.org under the Educational Events page. There may be a delay of several days before the information is posted, and your patience is appreciated. Once again, we would like to thank our webinar sponsors, AstraZeneca and Ipsen, and our scientific and medical affairs industry members, AbbVie, AngioDynamics, AstraZeneca, Ipsen, Pfizer, Rafael Pharmaceuticals, Tempus, TriSalus, and TYME. A survey will pop up once you leave the session today, so please take a moment to share your feedback. If you have any questions, please contact Patient Central at 877-2-PanCAN and ask to speak with an associate. This concludes the webinar. Thank you.